Hello everyone. Today I am going to demonstrate robot-assisted right radical nephrectomy. I have done very minimal editing of the surgical steps so that it can be reproduced. The key challenge in this case was large renal mass which was falling medially so that it was difficult for retraction and multiple renal arteries at the renal hilum. Contrast enhanced CT scan of abdomen with urography showed a large renal mass replacing the mid pole and lower pole of the right kidney. Two arteries can be seen arising separately from the aorta. There was no obvious infiltration into the ascending colon or duodenum or any adjacent structures. There was no obvious enlarged retroperitoneal lymph node. Before approaching to the surgical video per se, let us understand the basic anatomy and the vital structures around the right kidney and the step-by-step approach of right radical nephrectomy schematically. So as you can see, this patient having a large right renal mass. This is the upper pole of the kidney and this is the lower pole of the kidney. Upper pole having some residual normal parenchyma and the whole of the lower and mid pole of the kidney is replaced by a large kidney tumor. This is the aorta. This patient has two renal arteries. One renal artery is below the renal vein, other is cranial to the renal vein. These renal arteries bring blood supply from the aorta to the kidney. This is a renal vein which drains the blood from kidney to IVC. This is right gonadal vein which drains into the IVC directly. This is the ureter which drains urine from the kidney towards the urinary bladder. The ureter crosses the external iliac artery. This is the liver which lies cranial to the kidney, upper pole of right kidney. So, after ascending colon mobilization, these retroperitoneal structures containing this kidney and the renal hilum, renal vessels got exposed. So, at the starting, after the ascending colon mobilization, first step is to dissect this ureter and lift this ureter above. Then the renal hilum is approached gradually. First, what we do, we clip these renal arteries. This obstructs the vascular inflow from the aorta towards the kidney. After that, renal vein is carefully dissected and clip is applied to the renal vein. Next, perinephric dissection is done to isolate the kidney along with the perinephric fat and the covering aorta fascia from the surrounding structures. After that, careful mobilization of the right ureter is done up to its distal extent and clip is applied in the right ureter. Thus, this step completes the right radical nephrectomy and the specimen containing the kidney tumor along with the perinephric fat with the intact aorta along with the ureter and the cuff of the renal artery and vein are removed. Let's come to the port position. On the right hand of the screen, you can see the head end of the patient and on the left side is the leg end of the patient. From cranial to caudally, 4 ports are made in the same pararectal line. The extreme cranial port is the right working port followed by camera port. The L1 and L2 ports are inferior to the camera port. These are used for as left working ports. L1 I use for bipolar forceps and L2 I use for progress for retraction. A1 and A2 are two assistant ports. A1 is 12 mm laparoscopic assistant ports for suctioning and application of clips. A2 is 5 mm laparoscopic ports at epigastrium. This is used for liver retraction. Welcome to the surgical demonstration. The ascending colon is mobilized by incising the line of Told, that is the peritoneal reflection lateral to the colon. The colon is gently moved medially to expose the retroperitoneum which contains right kidney, renal vessels and ureter. When dissecting near the kidney, one has to be careful to dissect the colon from the medial surface of the kidney and renal mass. If you go too much lateral, you will reach the posterolateral surface of the kidney and kidney will start dropping. During colon mobilization, clear plane can be identified between the colon mesenteric fat, which has more orangish hue, and the perinephric fat, which has more lemon yellow color hue. Colon should be adequately mobilized so that gonadal vessels and ureter is seen at the caudal end, and in the cranial end, duodenum is visible. Adhesiolysis from the liver is done to free the kidney at its upper pole. Liver is retracted with a tooth grasper through 5 mm assistant port. Judicious retraction of the kidney along with the renal mass is done with third robotic instrument, that is the prograsp. Following adequate colon mobilization, duodenum is kocherized. Duodenal kocherization is required only for the right side. Duodenum should be kocherized adequately so that inferior vena cava is visible. Ureterogonadal packet is retracted with prograsp. Further dissection reveals gonadal vein, gonadal artery, and ureter. Ureterogonadal packet is lifted from the psoas muscle. Unlike left side where gonadal vein drains into the renal vein, in the right side gonadal vein drains directly into the inferior vena cava. Thus on the right side gonadal vessels are not sacrificed. Instead, ureter is dissected free from the gonadal vessels. Ureter is lifted off from the psoas muscle using retraction arm, that is the prograsp. As the large kidney tumor was falling medially, we use the retraction arm to retract the kidney mass superolaterally. Dissection is proceeded cranially towards the renal hilum. The ureteral packet along with the perinephric tissue within the aorta needs to be dissected free from the psoas as much as lateral as possible in this step. This allows adequate renal mobilization and adequate exposure during the hilar dissection. On approaching the hilum, renal vein is visible. Some accessory veins needs to be clipped and divided between the clips. One can appreciate one vein draining into the gonadal vein. The vein was dissected and cut between the clips. One can appreciate unusual insertion of right gonadal vein at the junction of renal vein with IVC. Gonadal vein is cut at its insertion between the clips. This allows increased exposure at renal hilum. Renal hilum is the most critical structure. It contains renal artery, renal vein and renal sinus fat. Dissection at the renal hilum should be very gentle, should be meticulous, and the movement of the instrument should be along the axis of the vessels. Any tubular structures near the renal hilum should be considered as potential renal hilar vessels and needs to be dissected well before dealing with it. Accessory renal vein superior to the main renal vein is dissected. It is clipped and cut between the clips. In this patient, there was two renal arteries. One can appreciate movement of the scissor and bipolar along the axis of the renal artery. This prevents any inadvertent injury. Renal artery cranial to the renal vein is dissected. Window behind the renal artery is created. Hemolock clips are applied to the renal artery. It is our practice to apply 3 clips proximally and 1 clip distally and cut between the proximal and distal clips. One small upper polar branch from this renal artery is clipped separately. On the right side, renal artery remains posterior to the renal vein. Sometimes it is difficult to dissect entire length of the renal artery. As the renal artery is not adequately dissected in appropriate length to apply all the hemolock clips, one clip is applied across the renal artery. Clamping the renal artery shutdowns all the vascular inflow towards the kidney. This allows dealing with the renal vein. Renal vein is adequately dissected from the surrounding tissue and a window is created behind the renal vein. After making proper window around the renal vein, hemolock clips are applied. These are extra large hemolock clips. 2 clips are applied towards the inferior vena cava side and one clip is applied distally. Between proximal and distal clips, renal vein is cut. After cutting the renal vein, the main renal artery, which was clipped previously and was behind the renal vein, can be seen. The renal artery is skeletonized by careful dissection from the surrounding structures to gain adequate length for clip applications. Renal artery is divided between the proximal and distal clips. After renal hilar control, the kidney is devoid of its both arterial supply and venous drainage. Rest is perinephric dissection outside the Gerota fascia. Ureter is clipped near its crossing with external iliac artery and divided between the clips. Following this, rest of the perinephric dissection is completed. After the completion of resection, any residual clot and bloods are sucked out with laparoscopic suction cannula. The resection field is irrigated and hemostasis is secured. Thank you for being my audience. Please subscribe to my channel, hit the like button and don't forget to comment. You can scan this barcode to reach out to me and get my contact. Stay updated for future posts. I'll be very happy for your suggestions, comment and queries. Thank you once again.